are dedicated trauma rooms.
You need a patient?
Can end up in other rooms. These are the primary rooms which we keep our critical and modified traumas in. They have all the resources available in the room or immediately available in the hallway to care for the trauma patients as far as airway, breathing, and circulation. Three things that are going to kill them the quickest. This is Dr. Milos pretending to be a patient, where the patient would roll in after the emergency medical crews bring them and transfer them to our care. This is Brian Dean, one of our emergency medicine physicians, who would be here to initially evaluate and stabilize the patient. I would be the trauma attending, again here to initially evaluate and stabilize the patient. We have techs and nurses to assist in IV lines, immediate sedation, and comfort care, and a nurse who's charting everything that goes on in the room to make sure that all the information is captured. If the patient is critical from this point, we will do whatever urgent airway control we need to do, circulatory control we need to do, or breathing control we need to do. The most common of those procedures being chest tubes and intubation for the patients. The patient will then move immediately out through to our next department. Any questions right now? Questions? We are now in our X-ray department. We have echocardiography, portable and non-portable X-rays, nuclear medicine, and at the end of the hall, our most common evaluation of critical patients, which is the CAT scanner. This is a state-of-the-art 64-slice CAT scanner, which we use in the most critical patients to obtain images from their head, their neck, their chest, their abdomen, and their pelvis for immediate assessment and evaluation. Any questions? At this point, if a patient is found to have life-threatening injuries needing to go to the operating room, we'll proceed this way. If the patient had hypotensive and life-threatening injuries which are identified in the trauma bay, we would bypass the CAT scanner and come to the operating room. This is where the patients with the most life-threatening injuries would come. We have an operating room available, 24/7, staffed, fully staffed for general, orthopedic, and neurosurgical needs. And the patients would come through these doors into the operating room, have whatever procedure they have, and then as we'll go up to the intensive care unit, where they would be recovered, stabilized, and further resuscitated.
Without going in there, is there anything visibly different between level 3 and level 2?
No. Nope. Just the staff. This is where we come off the elevators on the 4th floor, and we're now going to enter the intensive care unit, which has been newly renovated and expanded. This is one of our newly renovated state-of-the-art intensive care unit rooms, which patients would come if they did not require surgery or postoperatively if they had a procedure performed for our intensive care doctors, cardiologists, trauma surgeons to continue to care for in their recovery phase. Questions? Yes. After patients have been stabilized in the intensive care unit, they're ready to either go to the floor if they have no more pressing rehabilitation issues prior to discharge. If not, we have inpatient rehab where we take care of patients and their acute rehab needs, giving them 3+ hours of activity and rehabilitation with our physical therapists, rehab doctors, and occupational therapists per day. All right, this is Dr. Lovelace, our physical medicine inpatient rehabilitation doctor.
Hi, I am the medical director of the Comprehensive Inpatient Rehabilitation Unit. We have 14 beds here. We treat many of the trauma patients who come in, people who have fractures that need rehabilitation for walking and self-care. We treat a variety of other patients as well. And before people come to the rehab unit, we go to them to assess them wherever they may be, starting in ICU or the surgical floor or the medical floor. Myself and a team of therapists will assess the patient and make recommendations. We do have an intensive program here. It's 3 hours a day, at least, occasionally more if the patient needs more. A lot of people aren't physically able to do that much for a variety of reasons. In that case, we would refer them to a facility upstairs on the 5th floor called Mercy Manor. It's licensed as a skilled nursing facility. It's a lot like a nursing home, which is right here in the hospital, which makes it very convenient for patients, families. The physicians can continue to see the patient. And that's only 2 sessions a day, perhaps an hour and a half or 2 hours. So that slower pace can often be better for certain patients. So really whatever the patient's needs are, from intensive rehabilitation to a skilled nursing facility to outpatient or home, we provide all rehabilitation through Mercy.
One of the facts that we find most helpful is that because both of these are attached to our hospital, we're able to still continue to see our patients even though they have left hospital criteria and are now in rehabilitation type facilities. This is the case with Adam Rivers, who was transferred after the intensive care unit to our floor and then to this rehab unit for his therapy.